All right, let me pull that up for you and go ahead whenever you're ready.
So I know the ECHO project is a lot about diabetes, but because thyroid issues are very common, we decided to talk about that today. So I'm going to talk about goiter management. Next slide. So we'll define what that word means, how to evaluate it, and how to manage it. Next slide. So what is a goiter? Next slide. Is it an enlarged thyroid? Yes. Next slide. Is it referring to nodules on a thyroid gland? Yes. Next slide. So sometimes people talk about a goiter as an enlarged thyroid, but sometimes it's a completely normally sized thyroid gland, and they'll say that I have goiters on my thyroid, in which case they're using that word to refer to thyroid nodules. Next slide. So really, it's just a kind of old word that has a lot of non-specific subcategories. So when I'm writing for a thyroid ultrasound, sometimes for the diagnosis, I'll just write goiter. It's just a few letters instead of writing multinodular or whatever. And insurance does cover that as a diagnosis that will lead them to pay for the ultrasound. In my mind, it's really just any thyroid that is not 100% normally sized, normally textured, and whether it has lumps or bumps or anything. It's just anything that's not perfectly normal. Next slide. So this is not a goiter. This is a normally shaped, normally sized thyroid gland, no lumps or bumps on it. Next slide. This is a cartoon drawing of a very large thyroid gland. This would be called a goiter. Next slide. This would be called a uninodular goiter, and the thyroid overall can be normal size, but with that one little bump, it gets that term. Next slide. And this is a multinodular goiter. And again, the thyroid gland overall may be completely normal in size, but because of all the lumps or bumps, we could call this a goiter. So again, it's a very non-specific term. It just means something that's not completely normal in the thyroid. Next slide. Okay, next slide. So an average thyroid gland weighs about 25 to 30 grams, not that we're weighing our patient's thyroid glands. And when you get a thyroid ultrasound report and you're looking at the overall dimensions of the gland, which are reported on every ultrasound report, each lobe can be up to 6 centimeters and still technically be normal. So when you see in the summary that it says thyromegaly, sometimes radiologists will report thyromegaly when in fact the thyroid is not truly enlarged. So just look at it yourself, and if the dimensions are somewhere in the 5s or even low 6s and it doesn't look or feel to the patient like it's enlarged, it's maybe a little on the plumpy side, but it doesn't have to mean anything. Sometimes a thyroid gland could look big if you're looking at their neck, or if you're feeling it, it could feel like it's enlarged, and then you get an ultrasound and it's in fact normal. That's not uncommon. Thyroid glands could sit more forward or anteriorly in the neck. They could just seem more prominent, whereas they're not actually that deep. They could be normal overall size, but they're kind of fat and plumpy but short, so the overall volume or weight is normal. They could be tall but kind of skinny, wide, or kind of shallow. So they come in all sorts of shapes and sizes. One side does not have to match the other in terms of overall size. Just like every part of us, we are not 100% symmetric. Next slide. Okay, so if someone has an enlarged thyroid gland, from looking at it, from measuring it, from your ultrasound, do we need to worry about that or not? Next slide. Okay, so we really have to ask ourselves, if it's an enlarged thyroid gland without any lumps or bumps, it's just big, is that gland causing any obstructive symptoms or signs? Next slide. Okay, so you ask the patient, are you having any trouble swallowing, voice changes, hoarseness, any unusual cough? If they're lying down, are they feeling like this thing is weighing down on their neck so that they have trouble breathing? Do they say they have to lie on their side to sleep because their thyroid's pressing down on their windpipe? Next slide. And if you aren't sure if it's the thyroid or not. Suppose the thyroid is kind of average overall size, but they are complaining of symptoms like that, you could consider doing something in addition to your thyroid ultrasound, which maybe didn't reveal that the thyroid itself is truly the reason. You can do a swallow study and have them look, does the thyroid kind of impede any processing of food down the esophagus? And then you can explain to the patient that that's not why you're having the dysphagia, etc. Next slide. Okay, now those are all kinds of symptoms, and then signs that we'll find on exam are mainly the Pemberton sign. Next slide. So if a person is sitting there and their thyroid maybe doesn't even look particularly enlarged, but they're telling you about some compressive symptoms, have them put their arms up above their head like this, with their arms as close to their ears as they can possibly go, and you just look at their face. And if their face gets red, then that is a sign of obstruction caused by some compression in the neck, presumably by the thyroid there. And that in and of itself is an indication for surgery. Next slide. Okay, next slide. Okay, so what if you have an enlarged thyroid and it's not causing any obstructive signs or symptoms? There are no lumps or bumps on it based on your ultrasound. You can then reassure the patient that it is purely a cosmetic concern, not a medical concern. And, you know, you can watch it over time, but if they don't change anything about their symptoms to you and they continue to have a negative Pemberton sign, perhaps the thyroid is getting bigger, but it's always growing outward as opposed to kind of inward or downward behind the sternum or clavicles, then again, it is a cosmetic issue. You don't have to worry about it medically. Next slide. Okay, so if your patient says, I have goiters on my thyroid, so then we think, of course, about thyroid nodules. Next slide. So thyroid nodules are extremely common. If I took our ultrasound machine up and down the sidewalk, 1 out of about every 3 or 4 people has thyroid nodules. 1, 20, big ones, little ones, they're very, very common. I kind of explain them to patients as like freckles. You can have lots of freckles. They're not melanoma, they're just freckles. If we see them, we kind of check on them over time, make sure that they don't change and do anything funny. Or if they look funny right off the bat, then we investigate them further. So the size of a nodule is not the thing to pay attention to. You want to look at the characteristics of the nodules. Little nodules could have cancer. Little tiny nodules could have cancer, but they're not considered to be clinically relevant when they're tiny. Sort of conversely, very large nodules or nodules that you're seeing grow, because every nodule that you very first ever see that's 5 centimeters big at some point was 4 centimeters and 3 centimeters, and it can still be completely benign. So nodules don't change their cancer risk, specifically because of size. Also, the number of nodules does not change a person's risk of having thyroid cancer, in that each individual nodule comes with its own independent risk for having thyroid cancer. It is not increased simply because there's a nodule near it or multiple nodules in that thyroid gland. Next slide. Okay, so the only reason that we do care about these thyroid nodules is that because there is that little risk of thyroid cancer being in a thyroid nodule, and we don't want to miss it if it's going to become clinically relevant. So 95% of thyroid nodules of any size are benign, and that's an important thing to remember to tell our patients because they sometimes worry about them. And so we just want to look and make sure that those 5% nodules that have cancer don't get missed. Next slide. Okay, so how do we find out if there is cancer in a nodule? Next slide. Do we do a thyroid uptake and scan simply because we know that there's a thyroid nodule there? Next slide. No, we do not. Next slide. Think about thyroid uptakes and scans as only to be done in someone whose TSH is suppressed, indicating hyperthyroidism. These scans are only to figure out why someone is hyperthyroid. They are not to tell you whether a thyroid nodule, whether it's hot, cold, lukewarm, medium, neutral, I don't care. That cannot answer whether there is cancer in a thyroid nodule. So don't think of thyroid uptake and scans as the way to figure out if a thyroid nodule has cancer. It is only to be used and ordered regardless of what the radiologist says at the bottom of their ultrasound, like consider thyroid uptake and scan. No, don't do that. If their TSH is low, yes, then you want to know because the scan will help you figure out if they have Graves or something. But if you want to know if a nodule has thyroid cancer, you do a biopsy after you look at the nodules on an ultrasound. Next slide. So an ultrasound is the absolute best way to look at a thyroid gland, hands down. They can measure tiny little units. They can look at the back side, the front side, the side of every thyroid gland. If you want to think about a CAT scan to look at a thyroid gland, the only time that that would be indicated is if your ultrasound already indicates that that thyroid is extending down behind the clavicles or behind the sternum, because of course ultrasound can't penetrate bone. So you need a CAT scan kind of to assess how far down is that going, so that when you're sending them to surgery or whatever, they know kind of how deep they're gonna have to go in there. Next slide. Okay, so your ultrasound shows no nodules. Next slide. Okay, then what do you do with that thyroid that maybe could be a little plumpy? You know that there are no nodules on it. You can just follow it with palpation. You don't need to re-ultrasound an enlarged thyroid. If it doesn't have any nodules on it, just feel it once a year, or if the patient notes symptoms prior to that, tell them to call you and you can evaluate it. Next slide. So what if your ultrasound does show thyroid nodules? Then what? So here's what an ultrasound would look like. So looking there, I don't know if you can see my cursor. Can you see my cursor? Okay, so that's the nodule there. And then to the right, kind of at 4 o'clock, that giant circle to the right and farther over. Well, there's the trachea on the big circle with the sort of white hemisphere on the top. On the left, that black thing is the carotid. Then, of course, the thing that's marked is a thyroid nodule. So how do we know, does that have cancer in it or not? Should we biopsy that or not? The measurements at the bottom, it's 1.36 centimeters by 0.85 centimeters. Next slide. So we see that nodule and it's described at the bottom of the radiology report. We know how big it is and we looked at the general appearance of that nodule. It was a little bit darker gray than the surrounding area, etc. So the next question is, does it in fact need a biopsy? Next question, next slide. Okay, so how do we know? We go to our trusty American Thyroid Association guidelines. Next slide. And they provide us with these nice pictures, which we have posted all over our walls in the endocrine clinic to look at and refer to and teach our fellows. And so increasing risk of malignancy goes from the very bottom picture to the very top row. And we compare the way that those nodules look on our ultrasound of our patient to these nodules, and we decide on whether or not the patient's nodule looks like a low-risk nodule or a high-risk nodule. We don't look at the overall size, we look at the way that the nodule appears, its characteristics. So in the bottom, you see that it says benign, it's a black circle, that's purely a cyst. That has less than 1% chance of being a cancer. So if you look far to the right of that arrow, it says you never have to biopsy that thing. Then if you go up to the next row, second from the bottom on the left, it looks almost like a sponge. If you were to fill it with water, you can imagine that your sink sponge probably looks like that. Or if you squished it down, water might squirt out. So those are considered to be a very low suspicion for thyroid cancer. So if your person's thyroid nodule looks like that on the ultrasound, or if when we're, if they're referred to us and we see it, then if we look to the right, we say consider. It's not even recommend, it's consider doing a fine needle aspiration once that nodule is 2 centimeters or bigger. Now, consider means you don't have to. It means you could follow up with another ultrasound in 6 to 12 months to make sure it's stable and just keep an eye on it. The chance of it having a cancer is less than 3%. So if you do want to biopsy it, don't even bother until it's at least 2 centimeters because it's so unlikely to have a cancer in it. Then if you kind of go up to the top row, just to not belabor this point, you'll see very high suspicion looking nodules. And again, it's not a guarantee that there is cancer in there, but these are the nodules that just on their appearance have the highest chance of having a malignancy in them, 70 to 90%. So these we would biopsy at a smaller size, 1 centimeter or bigger, and it's recommended that you biopsy it, not just consider biopsying it. It is recommended. So if it has calcifications in it, if it has an irregular border, if it looks like it's kind of spreading outside of the thyroid gland, all sorts of things like that, that a good radiology report will comment on in its summary, or you just pull up these pictures from the American Thyroid Association guidelines and print them out and have them next to your computer and look at the actual ultrasound images yourself and do your own comparing. And if it looks like one or the other, then you know at what point to biopsy it, whether you ever have to biopsy it, etc. Next slide. Okay, so what if the report or your ultrasound images that you're looking at show multiple nodules and you can only biopsy one of them? How do you choose which one? Next slide. Okay. This is a multiple choice, so I can't see anybody, but you can think about it on your own. So if you have multiple nodules, you can only biopsy one. How do you pick one? You could wait for 6 months and see if one of them looks like it's changing. You could biopsy the largest one, or you could biopsy the nodule that looks scariest based on those pictures from the American Thyroid Association. I'll give you 4 seconds to consider your answers. Okay, next slide. So it's the one that has the highest risk. Next slide. So this is how I write my ultrasound FNA requests. When I put the order into Epic or write it on a prescription pad, I write FNA thyroid nodule biopsy the 1.3 centimeter left upper lobe nodule. Even if there are 15 other nodules in that thyroid that are bigger than 1.3 centimeters, if the 1.3 centimeter nodule has the calcifications in it, it's hypoechoic, it looks irregular, blah, 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 and the other ones look much more like those spongy ones I showed you on the previous picture, but they're twice as big, skip those big ones. Go for the scary one and just specify to the radiologist or whoever's doing your biopsy which nodule you want to biopsy. It will give you the highest yield. It'll be the best, most sensitive way to catch a thyroid cancer in that overall thyroid gland if you're very careful about which ones you biopsy. Next slide. Okay, when you get a biopsy, these are the results you could possibly get. The most common is benign, thankfully. Again, 95% of thyroid nodules are benign. So what do you do for a benign biopsy thyroid nodule? Some endocrinologists say that a benign biopsy means you really never ever have to look at that thyroid nodule again. I personally can't let go that easily. I always want to kind of check in on it. So I usually repeat an ultrasound in about a year. And then I would probably follow up just feeling it or repeating an ultrasound 2 more years after that, kind of stretching out how frequently I check on it, as it has already shown itself to be benign on a biopsy and stable on that follow-up ultrasound. And then I also tell patients, you know, if the plan's not to ultrasound for 2 more years, but in 6 months you're noticing something significantly different in your neck, just call me. We can do an ultrasound sooner than 2 years from now. We don't have to wait, but just on the presumption that nothing in there looks scary, we'll kind of stretch out our observance. So you could also get back results that say insufficient, and that means they just didn't have enough cells on the slide to make a diagnosis of benign or otherwise. So we repeat the biopsy in about 1 to 3 months. If the biopsy comes back as thyroid cancer, then this isn't a personal pat on the back. There's actually data to say that people with thyroid cancer have best outcomes if they are managed by endocrinology. So if possible, refer them to endocrine. But if there is thyroid cancer in there, definitely also refer them to surgery. And then I saved this category of FNA results for last because it takes a little bit of extra explaining. I call it the wishy-washy result. So it would say something like atypical or follicular lesion of undetermined significance or something like that. So then what is often done nowadays is that very same specimen that was taken out of the nodule and came back with these results is then sent for genetic testing. The one company is called Afirma. That's the one we use. So those cells in the thyroid that looked funny can get assessed for having bad types of genetics versus good types of genetics. And based on that result, we can say, you're all right, you don't need surgery, it's very unlikely to have cancer in it, versus the genetics of this nodule that looks a little atypical and funny probably has cancer. So best to go for a hemithyroidectomy, and we can find out most definitively that way. If it is cancer, depending on the size, et cetera, you may need the other half of your thyroid removed thereafter. Next slide. Okay, so sort of jumping backwards. It's your very first time seeing a patient. You either see a thyroid nodule when they're talking to you, or you're doing your exam and you feel a thyroid nodule. The very first thing you want to do is order a TSH. I know that seems funny because I think of thyroids in two ways. One is, how well is it working making thyroid hormone, which is determined based on blood tests alone, versus how does the thyroid look? Is it big, little, lumpy, bumpy? And almost always, those are two mutually exclusive categories. You can have the most beautiful looking thyroid and it could be overdoing its job or underdoing its job. Conversely, you could have the most funny looking thyroid and it's working perfectly well. So when you do see or feel a thyroid nodule, you still want to get a blood test to see, is that person hyperthyroid? Because then, if you remember back to the beginning, that's when we would order a thyroid uptake and scan to see why they're hyperthyroid. But if you feel a nodule, you still want to look at it with an ultrasound. And I don't care if they're hyperthyroid or not, or if it looked like a hot nodule or not. If it's got calcifications and looks scary, you can still have a cancer in a hot nodule, even though statistically it's less likely. Next slide. Okay, so this is what I just said. If the TSH is low and they're hyperthyroid, you could consider the scan. But also remember, if you're feeling a nodule, you want to actually get a good picture of it to assess the characteristics of that nodule and compare it to those pictures from the American Thyroid Association. And if it looks like a scary nodule, it's still going to need a biopsy. Next slide. Okay, a couple of last points. So when do you order an ultrasound? Next slide. Okay, really technically, you should only order it if you feel a nodule. You shouldn't order a thyroid ultrasound as kind of a standard workup for a thyroid evaluation because somebody says, I take levothyroxine, or I'm tired and my mom has hypothyroidism. An ultrasound to look at the structure of a thyroid gland is not a way to evaluate hypothyroidism or hyperthyroidism. It's just for feeling a nodule. Next slide. A lot of times we get the reports from the radiologist saying heterogeneous or homogeneous in the report. Next slide. Sometimes they even say heterogeneous thyroiditis, blah, blah, blah. You can't diagnose anything on a thyroid ultrasound. You can only describe. So heterogeneous and homogeneous are only descriptive terms of the background thyroid gland. It has nothing to do with nodules. It has nothing to do with anything. So heterogeneous is a coarse kind of texture to the thyroid gland, like a tennis ball. It's kind of rough, but there aren't lumps and bumps on it, versus the surface of a baseball, which is smooth. And again, no lumps or bumps on it. So the baseball is homogeneous, the tennis ball is heterogeneous. Like some people have that beautiful baby soft skin and other people have that coarse, rough skin no matter how much Nivea they put on themselves. So it's just a description of the background texture of the thyroid gland. It doesn't mean anything. Next slide. And that's it. So, any questions?
Thank you so much for that presentation. That was excellent, Dr. Perini.
Thank you.
Does anybody have anything they want to, comment on or any type of questions while we're in our discussion today?
That was a great presentation. I appreciated it.
Sure, thank you.
Put that all together.
Yeah, just practical. So,
Yeah.
That was, yes, thank you.
thank you.
I have a question. I mean, in terms of following up on ultrasound with this for this thyroid nodule, okay, what would be a time interval? Say the thyroid nodule didn't change for 2 years. That is sufficient to stop doing ultrasound on it, or we just keep following what the radiology says as
Yeah.
a primary care level I'm talking about.
Yep, I know what you mean. And then of course you worry if the radiologist recommends something and then you don't do it, and then something happens down the road, are you kind of liable because you missed following up what the radiologist recommended? So there's always kind of that concern. But, if a nodule has, first, I guess kind of two scenarios. It never needed a biopsy because it looked relatively benign, and then you check an ultrasound in a year, it's stable. I usually do one more about 2 years after that. And then I say, we'll follow with palpation unless the patient notices or I notice something that's changed, and then we'll do another ultrasound. So that's a personal way to do it, and our guidelines do not indicate that you have to continue doing ultrasounds forever for essentially a freckle on the thyroid gland. If it was biopsied and benign, again, there are some famous endocrinologists that I've gotten to ask, what would you do? And they don't even do a follow-up ultrasound. They count a negative biopsy, a benign biopsy, as absolutely definitive. And if that was the only nodule in the gland, they never do another ultrasound ever. They just feel the gland and go from there. So it's really kind of up to you. I would always feel their thyroid and see if it feels like something's new or different or more lumpy than what your notes said from last time you saw them or from what the ultrasound report kind of indicated. But for benign things or stable things, I would maybe do 2 follow-up ultrasounds and then be done with it most of the time.
Okay. I usually come across this kind of questions mainly when somebody has been diagnosed with thyroid nodule, and I have to mention in the problem list that there was thyroid nodule, but ultrasound was negative, just for the sake of future reference. The problem comes up when we are going to start the patient on GLP-1 agonist.
Yeah.
Where we need to make sure they don't have a thyroid cancer or a family history of thyroid cancer. Okay, that time patient gets concerned about that.
Yeah.
Okay, I know I can start it if it has not changed.
Sure.
Okay.
And actually, so thyroid nodules, again, are so common that if we didn't use our GLP-1s in anyone with a thyroid nodule, most of our diabetics would be going without those GLP-1s because a bunch of them have thyroid nodules. You can reassure patients that the type of thyroid cancer that's been associated with these medications is the medullary thyroid cancer, which is very rare. And it's the one most commonly, if you're gonna get it, you ask them if they have multiple endocrine neoplasia syndrome in their families, and let them really understand that it is a very unusual type of thyroid cancer that the GLP-1s are associated with. papillary and follicular thyroid cancers are the common thyroid cancers that we're actually looking for when we're doing these ultrasounds most of the time. Those have nothing whatsoever to do with the GLP-1s. Another thing to know to reassure your patients is that in Europe, on the GLP-1 black box warnings, they don't even list this, the medullary thyroid cancer issue, because it was only in rats who they found any increased risk of medullary thyroid cancer from using the GLPs in the trials. Humans have never really been found to get medullary thyroid cancer risk from these medicines, just rats. And it's a C cell issue. It's not a follicular thyroid cell issue. Medullary thyroid cancer is it's a horse of a different color. And so the rats have slightly different C cells than humans do. So that may be why they're more susceptible to it. So you can reassure your patients for all these different things. If they have a history of MEN syndrome, MEN, then of course you're gonna worry about a thyroid nodule, and then they need an evaluation for that syndrome. And again, medullary thyroid cancer is extremely rare, and it's not the usual thyroid cancer at all, at all.
One more question around the same thing is, many of the time patients get CAT scan done in the ER for some other reason, and there it comes about thyroid nodule.
Mm-hmm.
Okay, I know the CAT scan is as such is not a good test for the thyroid nodule. Okay, but because they mention it and they also comment on it, we need to get a follow-up ultrasound on that.
Yes.
Okay, now do you follow any different approach for those kind of situation, or you just do the ultrasound?
Do the ultrasound, same exact thing. And we also get them, they're doing the carotid Dopplers, and then they notice the thyroid. A lot of incidentally found thyroid nodules, you would do the same thing. Get an official thyroid ultrasound. If there are nodules there, you're gonna look at them and decide, is there anything in there that looks suspicious? And if so, look at the pictures. Is it big enough to warrant a biopsy or not? If it looks suspicious and needs a biopsy, you send it. If it looks okay, you just monitor. I would repeat an ultrasound in about a year, feel it, make sure it stays the same.
Thank you. Thank you for the excellent presentation.
Sure, sure.
Thank you, Dr. Pollywall. Sorry.
That's okay. Any other questions?
I might have one. Is thyroid removal or surgery, like to remove your thyroid, only occur when cancer is present, or does that happen if somebody's hormones are just very fluctuating as well?
So yes, it happens for thyroid cancer. If there is that positive Pemberton's thing where it's causing inlet obstruction just because it's so bulky and blocking blood vessels, that is a surgical indication regardless of whether there's anything, lumps or bumps or anything on the thyroid. And then every now and then it's a sort of a third line treatment for Graves' disease, which is the autoimmune hyperthyroidism. If they can't use methimazole or PTU as a medicine to slow their thyroid down, or they can't do a radioactive iodine ablation to slow their thyroid down for whatever reason, then surgery is a treatment for Graves' disease. And so that would be another potential reason for surgery.
Great, thank you so much.
Thank
If
you.
there's no other further questions, you guys good? I can make the announcement. All right, our next session will be on the 28th, and Hiba Kari will be presenting on oral manifestations of endocrine disorders. I will have that recap sent out to everyone, and thank you so much for joining. And again, thank you, Dr. Perini, for a wonderful presentation today.
Thank you. Bye-bye.
Bye-bye.